Okay, we will go ahead and get started. So I am Rebecca Armstrong, the Director of Patient Education and Engagement with the Canadian Breast Cancer Network. This session is being recorded and will be available on our website for anyone who may have missed it, and I'll share the link once the recording is available. You'll find previously recorded webinars on our website with a variety of different breast cancer related topics. I'd like to extend our sincere appreciation to our sponsors for today's session. Novartis, our gold level sponsor, Pfizer and Gilead, our silver level sponsors, and Bayer, Tercera, AstraZeneca, and Lilly Canada, our bronze level sponsors. The format for today's session will be a presentation by our speaker, followed by a question and answer period. Please feel free to use the Q&A function at the bottom of your screen to submit any questions you may have throughout the presentation. Our speaker today will do her best to answer your questions, but please note that she may not be able to speak specifically to individual situations without having a full, complete medical history. I'd now like to welcome our host for today's session, Kathy Amendolia, the chair of the board for the Canadian Breast Cancer Network.
And thank you, Rebecca. Welcome again, everyone. Thank you for joining us today. I'm pleased to welcome and introduce our guest speaker, Dr. Brooke Wilson, who is a medical oncologist at the Kingston Health Science Center with a focus on breast and gastrointestinal malignancies. Her research interests include health service modeling, resource stratified guidelines for cancer care, and secondary analysis for trial data sets. Dr. Wilson, it's great to see you, and thank you for being here today.
Thank you so much for the invitation. It's a pleasure to be here with you all. I'll go ahead and share my slides.
Yes.
Please do.
Okay, are you all able to see that? Okay, I'll take silence as a yes.
Yes, we are.
All right, so thank you to everyone for joining today. As mentioned, my name is Brooke Wilson. I'm a medical oncologist here in Kingston at Queen's University. And I will spend the next hour going through some introduction to metastatic breast cancer. I do have a few disclosures. So I have honorary and consulting fees associated with AstraZeneca, Gilead, and Novartis. And as was already mentioned, while I will do my best to answer your questions and provide you with information, I will not be able to provide you with specific advice on your unique situations. But I hope that what we cover today will help empower you to get the information that you need and to make informed choices about your own treatment options. Okay, so the objectives over the next hour are to provide you with an overview of metastatic breast cancer. I'm going to talk a little bit about what metastatic breast cancer means in terms of prognosis. We'll go through the common types of metastatic breast cancer, as well as some of the common treatment options. And then finally, I have a section at the end and actually throughout the presentation where I've sort of smattered in common questions that I get in clinic that we can hopefully use as discussion points to go through some important topics. So in order to cover those objectives, the outline is in 3 parts. We'll talk a little bit about what is metastatic breast cancer, then we'll go through a treatment overview for the various subtypes, and then some of these common questions that I get frequently. Okay, before we launch into that, I just wanted to take a moment. I know the language of cancer and the vocabulary that you are required to learn when you are diagnosed with breast cancer can be quite challenging and overwhelming. So just so we all start on the same page today, I will use words interchangeably for cancer spot, lesion, metastasis, tumor deposit. For a medical oncologist, these all mean the same thing. I'll also talk about lines of therapy, and by that I mean the number of treatments that you get sequentially during the course of your disease. So for example, first line is the first treatment that you get, second line is the second treatment, and so on and so forth. And then finally, we are going to touch on something called a biomarker throughout the presentation. So a biomarker may not be a familiar term to many. It's basically a marker of some kind. It can be many different things. It can be a blood test, a lab result, a genetic result, even a patient characteristic, but they're things that help your doctors decide whether a drug is the right one for you. Okay, so with those terminologies in mind, we'll launch into what is metastatic breast cancer. And some of this will be familiar, I'm sure, to many of you. So we know that breast cancer starts in the breast. There are two dominant types of breast cancer. One is arising in the lobules of the breast, and the second arises in the ducts. Some of you may also have heard terms like carcinoma in situ or DCIS or LCIS. These are non-invasive types of breast cancer, so they're not a true breast cancer. They're like a precancerous change within the breast, but do increase your risk of subsequently developing what we call an invasive cancer. Breast cancer is very common in our community. Of course, it affects women more than men, but I think this highlights that men are not unaffected by breast cancer, and about 1% of patients who develop breast cancer, in fact, are men. 1 in 8 women will develop a breast cancer in their lifetime. So this is a disease that is very common within our populations. Breast cancer is, in fact, the second most common cancer in Canada. There are a number of well-recognized risk factors for breast cancer that are listed at the bottom of the figure here. Things like aging being one of the most common risk factors for breast cancer, as well as family history, genetic mutation, status, alcohol intake, being overweight. Breast cancer are diagnosed in women over the age of 50. Okay, so what is metastatic breast cancer as compared to breast cancer itself? Metastatic disease occurs when the cancer has spread beyond the place that it started, which is the breast. The most common places that breast cancer will travel to include the bones, the lung, the liver, and the brain. And it's important for patients to understand, if you're then told that your breast cancer is in your lung, you don't have lung cancer. You have breast cancer that has traveled to your lung. And the treatments that you will be offered focus on breast cancer treatment, not lung cancer treatment. There are different types of breast cancer, and we broadly classify these based on the type of receptors that are expressed on the surface of a breast cancer cell. There are 3 important receptors to think about. The first are the estrogen and the progesterone receptors, written here as ER and PR, and together they make hormone receptor positive breast cancers. We then have the HER2 receptor, which is another important growth pathway for cancers. And then finally, if your cancer does not express any of the hormone receptors or the HER2 receptor, then you're classified as having triple negative breast cancer. Triple negative tends to be the most aggressive subtype and affects about 15% of our population. Whereas HER2 positive affects about 20%, and then the remainder are ER and or PR positive breast cancers. So we talked a little bit about the places that breast cancer can spread to. I think it's also important to recognize that depending on the type of breast cancer you have, meaning is it hormone receptor positive, is it triple negative, this can affect the likelihood of where your breast cancer might spread to. So for example, brain metastases are much more common if you have hormone receptor negative breast cancer, so a triple negative breast cancer, or if you have a HER2 positive breast cancer. Patients often ask, how did my breast cancer spread from my breast to other organs? And there are 3 main ways that breast cancer can spread throughout the body. The first is through the lymphatic system. I explain the lymphatic system to patients as sort of the immune highways of the body. The lymph system spreads throughout the body, and lymph nodes are a common way and first point where breast cancer will spread to. Breast cancer can also spread directly by, for example, extension through the skin planes. And then finally, the third common mechanism is through the bloodstream itself. Patients may also hear the term de novo metastatic breast cancer or recurrent breast cancer, and I think it's important to understand these terms as well. De novo metastatic breast cancer refers to breast cancer that was metastatic at the time of diagnosis, and this accounts for about 5 to 10% of breast cancers. The remaining types of metastatic breast cancer will occur in patients who had an early breast cancer and then unfortunately had a recurrence. About 30% of patients who have an early breast cancer will eventually develop metastatic disease, and that risk is determined in large part by the features of that initial breast cancer. Okay. When faced with a diagnosis or potential diagnosis of metastatic breast cancer, patients may often wonder what tests they should expect to have. The diagnosis is usually made on imaging, which can consist of a CT scan, a bone scan. Some patients may also get a PET scan, but this is not always needed or helpful. Blood tests themselves cannot diagnose cancer at this point in time, but your doctor will be able to use them to help monitor your treatment and the drug and the effect of the drug on your body. A biopsy is often required, but sometimes not if you had early breast cancer and then a recurrence. But often a biopsy can helpful to the diagnosis. And then find testing. Not everybody with metastatic breast access genetic testing, but it can be a very on what type of breast cancer you might have, called a survival curve. And as you look into literature, you will come across these curves, horizontal axis, and on who are alive at any of these time points. You can see that there are significant differences depending on the type of breast cancer. So for example, here in purple are patients with triple negative breast cancer, and they tend to have the worst survival as compared to the other subtypes of breast cancer. This line that I've put here in the middle is what we call the average survival time. So if we find the point where this purple line intersects with this average line, we can see that average survival for triple negative breast cancer is somewhere between 12 to 18 months. But there is some good news. Overall survival outcomes for breast cancer have improved over time, as illustrated here. You can see if we look at the light yellow line, our survival outcomes over time from 1993 to 1999. And then here in the dark orangey red color, our survival outcomes from 2010 to 2015. And as you can see, the number of people alive over time and that curve is shifting lower and lower, suggesting that the risk of dying from breast cancer has been decreasing through these time periods. This is another question that I often get asked that I think is important to understand. Patients will often say, I had early breast cancer and then I had a metastatic relapse. Why didn't my doctors do regular CT scans in order to pick up my breast cancer recurrence early? And while it may seem that early detection might improve survival, in truth, that has never been demonstrated. And therefore, early diagnosis through routine CT scans does not improve overall survival or quality of life. We also don't have clear evidence that starting treatment early before symptoms develop will improve your cancer outcomes either. And so for that reason, early diagnosis and early start of treatment may not improve survival, but it can have negative impacts on quality of life, both through the anxiety of knowing that your cancer has recurred, but also through being exposed to treatments earlier that may or may not lead to longer survival if they had been started later when you have symptoms. The other question patients often ask in clinic when they've been really newly diagnosed is what supports are available to them. Obviously, your doctors and nurses will play an integral role in guiding you through your medical choices. Early palliative care referral can be very helpful and will often be recommended if you need symptom support. I find our social workers are a very helpful resource for navigating the many government forms that need to be filled out and also provide psychosocial support. Dietitians may be involved if you have nutritional support needs. Cancer pharmacists are very useful, especially if you have questions about interactions with other medications you might take. And then finally, patient support networks like the one we are with today can be a great resource for patients. Okay, So with that, we'll move into the bigger part of the talk, which is reviewing some of the treatment options for metastatic breast cancer. This is a bit of a honeycomb diagram that sort of covers many of the options that we'll discuss today. Metastatic breast cancer is treated from a multifaceted approach. These treatments can involve hormone therapy, targeted treatment, radiation, bone-targeted therapies, chemotherapy, HER2-targeted therapies, and not on this picture, but sometimes surgery, although as we'll discuss, this plays a very minor role in the context of metastatic disease. I think this slide is one of the most important ones that I will show you today. The goals of any treatment for metastatic breast cancer are to try and improve two things. Number one, the quality of life through symptom control, and secondly, the duration of life. As we look at the treatment available options for hormone receptor positive breast cancer, which is from now on going to be called HR+, so hormone receptor positive, they largely fall into three buckets. The first are endocrine therapy treatments, the second is chemotherapy options, and the third are a group of drugs that we call targeted therapies. I've listed here some of the main drugs. I'm not going to go into the mechanisms of action or the details of why one might be chosen over another, but I will provide some big picture overview of how these various types of therapies can work. So one of the first things patients want to understand is, what does it mean to have hormone receptor positive breast cancer? And I usually describe this to patients as the estrogen in your body, or the hormones that your body produces, are kind of like a food that are helping your cancer cells grow. And we can exploit that pathway by blocking those estrogen pathways, and that sort of starves off the growth of those cancer cells. So in a simplistic diagram here, the estrogen molecule binds to this estrogen receptor, which then goes and binds to the DNA of your cancer cells and causes them to divide and continue to grow. So if we can block that pathway, we can try and stop that growth. Some patients will often say to me, well, I'm already postmenopausal, so I don't have a lot of estrogen. Why do you need to block my estrogen pathway? And the reason is that even when your ovaries have stopped producing estrogen, your estrogen is still being produced by other pathways in the body. And it's largely through the conversion of testosterone and other hormone precursors into estrogen in peripheral tissues. That activity or conversion is mediated by something called an aromatase enzyme. And therefore, a main treatment approach that we use for patients with estrogen receptor positive metastatic breast cancer is a drug class called aromatase inhibitors. This blocks that conversion and therefore lowers the rates of estrogen and estradiol in your blood and starves off those cancer cells. The second big type of treatment that you may hear about is tamoxifen, and tamoxifen is a little bit different from those aromatase inhibitors, or AIs. Instead of binding to that estrogen receptor and stopping that downstream activity, tamoxifen binds to that estrogen receptor and stops estrogen from binding in the same place. And if it can't bind there, then those downstream activities don't happen. So a slightly different mechanism, but the bottom line is we're in all of these ways trying to stop that estrogen receptor from leading to downstream activity. Women who are premenopausal will often wonder also, how can they block their pathways? If their ovaries are producing a lot of estrogen, then blocking those peripheral conversion pathways through aromatase inhibitors I just described will not be effective, because their ovaries are just going to produce the estrogen. So in this situation, we have a few tools we can utilize. The first is we may sometimes perform an oophorectomy, meaning removal of the ovaries. If that isn't an attractive or feasible approach, then we will give drugs to shut down that ovarian axis and render a patient what we call chemically menopausal. Okay, the next big class of drugs that I want to spend a little bit of time talking about is something called the CDK4/6 inhibitors. These are a newer kid on the block in terms of treatment options for metastatic breast cancer and one of our most important treatment available options right now. They are what I would classify as a targeted therapy. Sorry, I am in the hospital. Bear with me. Okay, sorry about that. Oh. Okay, apologies, busy day upstairs. These targeted therapies are combined with hormone therapy, so they're not usually given alone. And there are 3 of these drugs that are currently available on the market: palbociclib, ribociclib, and abemaciclib. When used in combination with hormone therapy, they have been shown to improve overall survival. And at the moment, they are our first-line therapy that is most commonly used for ER or hormone receptor positive metastatic breast cancer. Throughout the talk, I'm going to put little trials there in case anybody has interest in digging into the literature a little bit more. There are 3 main groups of trials that led us to adopt this treatment as the first treatment option we use, and they're listed there for your reference. Patients often wonder, well, they're not chemotherapy, they're not hormone therapy, how do they really work? And up in the graphic there is a picture of cell cycling. So cells are constantly cycling through a growth phase, a replication phase, and these drugs are working to block that cell cycling pathway. It's important to know that while I say combining hormone therapy with these CDK4/6 inhibitors is the most commonly used first-line therapy, for some patients it's still very reasonable to proceed with hormone therapy alone in the first-line setting, and this is an important trial that supports that. The common side effects you may experience from a CDK4/6 inhibitor include fatigue. There can be hair thinning, but unlike chemotherapy, where we often find complete hair loss, it is more thinning rather than complete loss. These drugs can cause some challenges with blood counts, so if you're on them, you'll be familiar with the need to do frequent and regular blood checks. They do sometimes cause low-grade nausea, but not usually to the same degree as chemotherapy. And there are a number of important blood tests that we will monitor, including liver function and kidney function. There are rarer side effects that cause inflammation to lungs and liver that we will also keep an eye on when using these for patients in practice. Okay, so if you are a patient who has perhaps been prescribed or is considering starting a CDK4/6 inhibitor with hormone therapy, what can you expect? We know from the clinical trials that inform these decisions that the average time that patients will stay on this first-line therapy is about 18 to 24 months. Now, an average is exactly that. That means that some people will not respond as well and will be on that treatment for a much shorter duration, and then other people will have a long period of response and might be on that treatment for a longer period of time. During the time that you're on this treatment, you'll likely get scans every 3 to 4 months to monitor your disease and regular blood check as well. Now, if you are in a situation where you've had your first-line therapy and unfortunately your cancer is starting to grow, what happens next? So this is when we would move on to what we would call a second-line therapy option. And for hormone receptor positive breast cancer, these treatment options are increasingly being driven by this term biomarkers. Some patients might get more hormone therapy. Other people might get this in combination with a targeted treatment. And then some patients may go on to get chemotherapy in the second line. So there is some variability about what might happen. When I talk about a biomarker here, what are we really looking for? These are some mutations that we are looking for that can help guide the selection of targeted treatments. We have a number of targeted treatments that are available or funded for us at the moment. Capivasertib is one targeted treatment that if you have a mutation in one of these things, you may have access to this drug. There are some other drugs that are also targeted therapies that are either available through an access program or unfunded, but you may wish to discuss them with your doctor. We're also looking for something called an ESR1 mutation. This is a biomarker that tends to suggest the patient is going to be resistant to further aromatase inhibitors. We can still use a drug called fulvestrant, which is a different type of way of blocking the hormone receptor pathway, which I'll show you in a minute. And then sometimes we might even be doing another biopsy to look for repeat testing of that estrogen, progesterone, and HER2 pathway, because sometimes breast cancer can change. And a repeat biopsy will help to make sure that we're choosing the right drug for the current situation. So fulvestrant is a very commonly used second-line treatment that is still targeting the hormone pathway, but in a slightly different way. So fulvestrant binds to that estrogen receptor and actually triggers degradation or breakdown of that estrogen receptor. Unfortunately, it doesn't tend to work for very long if used alone. So on average, patients will be on this drug for about 3 months before it stops working, which isn't a very long time. When we're able to combine it with some of the targeted treatments I outlined on the previous slide, we can end up with longer progression-free survival time, so meaning the cancer is stable on imaging for a longer period of time, closer to 6, 7, 8 months. So let's say you've been through your second-line treatment option and it was still hormone targeting, and now the cancer is progressing again. What other options are still available to you? In this case, we will typically need to think about moving towards chemotherapy. So this is a busy slide. I don't expect you to look at the details, but I wanted to just illustrate how chemotherapy typically works. And at the center of this slide is a cell, and at the center of that is DNA. And chemotherapy typically works to block the pathways for DNA replication. Different drugs will do this in very different ways, but the bottom line is that by preventing that DNA replication, you prevent the cells from growing and dividing and continuing to increase in size. Patients will often ask, what is the right chemotherapy drug? Earlier, I showed you a long list of chemotherapy drugs that are available for ER positive or hormone receptor positive breast cancer. How are we choosing which is the right one for the right patient? And in reality, for older chemotherapy drugs, there is not strong data on which one should be used first versus second versus third. So we will often choose the drug based on the side effect or toxicity profile of the medication and also the patient's preferences and values. So for example, a commonly used drug that I use very frequently as the first chemotherapy choice is something called capecitabine. It has some advantages. It's an oral therapy, so you take it as a pill at home. It doesn't typically cause hair loss. It can cause some GI symptoms and rashes. Other therapies include intravenous options like paclitaxel, which does cause hair loss and can cause neuropathy and allergic reactions, doxorubicin, and carboplatin with the side effects listed there. So the main message being, the decision in terms of chemotherapy can vary from patient to patient, and it's important to have a discussion about what your preferences and values are if you're faced with this decision. This is another question that I frequently get from patients who unfortunately have had a metastatic relapse. And that is that in early breast cancer, we're often combining many chemotherapy drugs together. So if you have metastatic disease, which is a more serious diagnosis, more advanced, more life-threatening, why are we only using one chemotherapy drug at a time? And that's a really important question. The reason is that the goals of treatment in the metastatic setting are different. They're not to cure the cancer, they're to slow the growth and preserve quality of life. And for that reason, we don't have any evidence that giving multiple drugs together is going to give you a better cancer outcome as compared to using those same drugs in a sequence. So one after the other. We also do know, though, that giving multiple drugs together at the same time causes more side effects and therefore can have a greater impact on quality of life. So usually we will use one chemotherapy drug at a time. There are sometimes situations where you still may have a recommendation for combination therapy, and that's often if we feel as clinicians that we need rapid tumor shrinkage in order to improve symptoms and get control of the disease. Okay, so let's say you've now gone on to a line of chemotherapy and unfortunately the cancer is growing again. What other options are still available? The reality is we still have quite a number of treatments because of this approach of sequencing chemotherapy. As we get further along, there are also newer chemotherapy drugs that may become available to you that are funded depending on the situation. And these are drugs called antibody drug conjugates. They work in a slightly different way, and they have an interesting structure and way of delivering their chemotherapy. So looking over here, this is sort of an illustration of what these drugs are. The components in blue are targeting binding to an antibody, and an antibody can be something on the surface of the cancer cell, like the HER2 receptor that we talked about, or many other types of markers on the surface of a cell. And, oh, and then we have here in red, this is actually the chemotherapy. So it's bound to this molecule that is going to bind to the surface of the cell. And this assists in making sure that the chemotherapy drugs are getting to the right place in the body. The two most common antibody drug conjugates that we use right now for hormone receptor positive breast cancer are a drug called sacituzumab govitecan. The names are complicated to say. And then another drug called trastuzumab deruxtecan. And there are the two trials that inform these treatment decisions if they are of interest to you to look up. So this is another way of illustrating how these antibody drug conjugates work. They bind to this surface receptor. So as I said, something like HER2. They then get pulled into the cell where they undergo a bit of a process of breaking apart the components of the molecule. And that releases these chemotherapy pieces to directly work inside the cells that express this original receptor. So it's like a way of giving the chemotherapy targeted to the cells that we want to get it to. That being said, these are fantastic drugs. They have revolutionized the way we are approaching and treating cancer, but they still have many side effects that are typically chemotherapy related. Things like nausea, diarrhea, hair loss, fatigue, infection risks, and mouth ulcers are all very common with these antibody drug conjugates. Okay. So we've covered sort of the broad picture of ER positive or hormone receptor positive breast cancer. I wanted to shift gears now and spend a bit of time talking about triple negative breast cancer and the treatment in metastatic disease. You'll notice here that a lot of the chemotherapy drugs that I've listed are the same as what we have available in the hormone receptor positive population. So I won't go through that again, but what I want to spend a little bit more time talking about is immunotherapy, which is an important emerging option for triple negative disease. Before we dive into that, patients often ask me, why is triple negative breast cancer so much more challenging to treat? Why are outcomes worse with this type of breast cancer compared to others? And it's because it is typically a more aggressive type of breast cancer, and it lacks those drug surface targets for drug development. So that estrogen receptor and that HER2 receptor are not there. So we don't have those biomarkers that we can target drugs to in the same way. As a result, chemotherapy is the most important treatment that you will typically have access to, but we do have these new antibody drug conjugates that can be useful as well as immunotherapy. So immunotherapy, how does it work? I usually describe this to patients as sort of taking away the brakes on the immune system. So in this panel here, this is a cancer cell, and this is something called a T cell, which is important for your own body's ability to fight off cancer. Here you can see an interaction or a lock and key scenario that's happening between a molecule on the tumor cell and a molecule on the T cell. And this interaction or lock and key is basically saying to the immune system, don't kill me, I'm a normal cell, don't touch me. So that's obviously problematic because then the immune system can't go in and kill off that cancer cell. So we have developed drugs that block that lock and key interaction. So they stop those two parts of the tumor cell and the immune cell from binding. And when that interaction doesn't happen, it's like removing the brakes for the immune system. That immune system can then say, oh, that's an abnormal cell, I need to go and kill it, and start attacking the cancer cells themselves. So one common question I get is, I have triple negative breast cancer, why didn't I get immunotherapy? Shouldn't everybody who has triple negative breast cancer be getting immunotherapy? And the answer to that is unfortunately no. Immunotherapy is only shown to be effective for triple negative breast cancer if you have a specific biomarker. So here comes that term again. And in the case of triple negative breast cancer, the biomarker that we're looking for is something called the PD-L1 CPS score. And you don't need to remember that, but essentially it's a marker that helps us understand whether chemotherapy will be useful to you. If you do have this biomarker, then your doctor will likely recommend combining immunotherapy with chemotherapy. And the important trial that showed us that that led to improved survival is something called the Keynote 355 trial, which is there for you to look up if that's of interest. Immunotherapy works in a very different way to chemotherapy. So when I'm talking to patients about it, I usually say that since we're trying to wake up that immune system to detect those cancer cells, the main side effects are if we overshoot and the cancer is no longer the only thing that the immune system is fighting, but instead the immune system starts to also fight normal cells. And anything from the tip of your head to the tip of your toes can really have an immune-related side effect. And I've listed some of the common ones and serious ones here. The most common things, though, that we see are rash, low thyroid hormone that means that you have to take a pill for the rest of your life, and tiredness. There are more serious side effects like inflammation of the lung, the liver, the bowel, the nervous system, and brain structures, and all of these can, in some unfortunate cases, be life-threatening. For most patients, if you develop an immune-related side effect, we will treat it with steroids, which tries to dampen down that immune activation that was triggered by the immunotherapy. This is another question I get a lot. If you have, for example, hormone receptor positive or HER2 positive metastatic breast cancer, why can't I get immunotherapy? And the reason is that right now we don't have strong evidence that it is going to improve your overall survival. There is a lot of research going on in this space, and eventually we may use it in a broader population of metastatic breast cancer patients, but right now it is not available outside of triple negative breast cancer or clinical trials. Okay. I showed you before the outline for the treatments for triple negative. We talked about chemotherapy. We've just covered immunotherapy, but there is still one targeted treatment option for breast cancer that is triple negative that can be useful, and that's something called a PARP inhibitor. PARP inhibitors are not funded for metastatic breast cancer, and the reason is that they are not clearly better than chemotherapy. So some patients may still choose to pursue this option because they might like the idea of an oral pill, but it is not freely available, and therefore there is a substantial out-of-pocket cost. This drug is also only useful for certain patients with triple-negative breast cancer, and the biomarker that we're looking for this particular drug is something called a BRCA mutation. And this is one of the reasons that doing genetic testing for metastatic disease can be very helpful in understanding what drugs might be useful to you now or in the future. The trial that led to us using these types of drugs for this situation is called the Olympia trial. Okay, so this is an overview written by some colleagues in Canada on the current landscape of what we usually do for triple-negative breast cancer. As we've discussed, if you have this PD-L1 marker, then you will typically get pembrolizumab, which is immunotherapy with chemotherapy. If you don't, you will typically get single agent or sometimes combination chemotherapy if needed. And then if you have this BRCA mutation, perhaps you will consider specific types of chemotherapy or those oral targeted treatments, although they are not funded. When we get beyond the success of that first-line treatment and we need to look at second-line treatment options, then this antibody drug conjugate that I mentioned to you early is one of the most common drugs that we are using today. So sacituzumab govitecan is the name of that antibody drug conjugate, and the trial associated with that is called the ASCENT trial. Okay, so what are the main types of treatment now for HER2-positive breast cancer? Again, we've talked a lot about some of the standard chemotherapy, and that remains the same on this figure. But what we'll focus on now is some of the HER2-directed treatments that we have, as well as some of these antibody drug conjugates, where the antibody is directed to this HER2-expressed molecule on the surface of the cell. The types of drugs we have available for HER2-positive disease vary. Some of them are called monoclonal antibodies. The name isn't important, but basically they work to bind to these surface receptors on the cell. Other drugs will get taken inside the cell and will work in a different way inside, and those are usually oral pills that you might be recommended, things like lapatinib, neratinib, and tucatinib. And then over here, we see these antibody drug conjugates that are brought into the cell and work in a different way. Things like TDM1, TDXD, and trastuzumab duocarmazine. That is a newer drug that is not yet available in Canada. Okay, so if you have been diagnosed with HER2-positive metastatic breast cancer, the most likely first treatment that you will receive has been pretty standard since 2015, and it consists of two drugs that target that HER2 receptor. They're called trastuzumab and pertuzumab. They are not chemotherapy, and they are combined with one chemotherapy drug, typically a drug called paclitaxel. The average time that you would be on this treatment is about 18 months, and we would usually stop the chemotherapy part after about 6 months, and then you would continue just on these targeted treatments. For most patients, quality of life is quite good when the chemotherapy component is dropped. And if your disease is also hormone receptor positive, this is when we would typically add in the hormone therapy as well. The common side effects with trastuzumab, it's usually quite well tolerated, but it can rarely cause some heart pumping issues, so you will usually get a regular heart test every 3 to 4 months. Pertuzumab, on the other hand, has a few more challenges, particularly in terms of diarrhea and rashes. And then finally, paclitaxel, we've already discussed, is an intravenous treatment that can cause neuropathy, so numbness and tingling to the fingers and toes, infections, rashes, and allergic reactions. If your cancer has progressed after your first line of treatment for HER2-positive breast cancer, we have some very exciting drugs available in the second line. And I say exciting because they have led to some improvements in overall survival compared to our previous standard options. So the most important drug here is called trastuzumab deruxtecan. And on average, patients will be on that drug for about 14 months. and average survival from the time of starting that can be up to 52 months. So survival can still be quite long with HER2-positive breast cancer. But I think this is an important reality to recognize. This is data out of the United States, but we face similar challenges in Canada. And that is that despite the availability of very good second-line treatment options, only about 40 to 50% of people with HER2-positive metastatic breast cancer will ever go on to have a second line of treatment. So while those survival numbers look good for those who get on to second line treatment, there are a number of patients who unfortunately don't reach that milestone. If you've had your second line of treatment with trastuzumab deruxtecan and you are still in need of a third or fourth line, there are still drugs available, and I list them here. Common ones would be to use an older drug, in fact, the first antibody drug conjugate that we ever had in medicine, called trastuzumab emtansine. Or sometimes we'll use a combination of trastuzumab with some chemotherapy, capecitabine, and then an oral drug that targets HER2 called tucatinib. So that sort of wraps up the component of the specific drugs we use for the various types of metastatic breast cancer. But there are some drugs that might be used across all types of metastatic breast cancer, so they're not specific, and I wanted to highlight them. So these are drugs called bisphosphonates, or drugs that are typically used for patients who have osteoporosis, and they're used to help to keep your bones strong. This is important because if you have breast cancer in your bones, then you might have a higher risk of bone pain, but also bone fractures. And so these drugs usually given as an injection every 3 months, sometimes once a month, and sometimes every 6 months, depending on the dosing and the schedule chosen. Another important treatment is radiation. Patients will often ask, is radiation a big part of my treatment? And while drug-based treatment is the most important component, radiation plays a very important role in specific management of pain. Bony lesions or bony cancer spots can be very painful for patients, and they tend to respond quite well to the use of radiation. Radiation in this context is usually given as a single dose or sometimes 5 days in a row. The treatment, if you're targeting spots in the brain, will be different, and I'm sure your doctors would explain that to you if it's needed for you. So we're getting close to the parts that I had prepared, but I wanted to spend some time going through these common questions that I get in clinic from patients. Hopefully they're of interest and use to the audience as well. So patients will often ask me, how long am I going to be on my treatment? And this question comes, I think, in part from patients who have experience in the setting of early breast cancer, where the duration of treatment is typically defined. But because this is a different situation where we are unable to cure the cancer and the objective is to keep the cancer well controlled and slow its growth down, generally patients will be on some form of cancer-related therapy for the rest of their life. The time that you'll be on each of these lines of therapy will depend on a couple of factors. Firstly, is this drug still working to control your cancer? Second, is the tolerability or toxicity profile of the drug still acceptable to you? And third, are your goals of care still to continue on active therapy? So it's important to consider all of these things as you make your treatment decisions and discuss them at each time point with your doctors. I think it's also important to highlight that treatment breaks can be very important for quality of life. The idea of being on some treatment for the rest of one's life can be very daunting and challenging. So it's very important to think about times where you might be ready for a treatment break for a family trip, a life event, or you've just had enough and you need a little time away from the cancer center. Patients often also ask, how often will you monitor my disease? How often will I have imaging? The most common types of imaging that we will do to monitor your breast cancer are CT scans and bone scans. Some patients might also get brain scans, but not everybody. And how often you get your scans can change based on how you're doing, what line of treatment you're on, On average, patients will typically be scanned every 3 months, but if your disease has been stable for a long time, then those timelines might get pushed out a little bit. So it can be an individual decision. This is another one that I get asked more and more every day. Patients coming in asking if they can simply have a blood test to either diagnose or monitor their cancer. And while I do think the future may head in this direction, this at this particular point in time is still not a routine practice. In this picture, you can see a tumor cell here. And this tumor is shedding or releasing small tumor cells into the bloodstream, which is this right here. It also releases little fragments of DNA into the bloodstream. And so we can draw blood and detect these circulating tumor cells and these pieces of DNA and follow them over time. There are potential advantages there in terms of watching for small amounts of cancer that could come back, for detecting mutations that help guide our treatment decisions, and maybe one day in the future, even for screening and detecting cancer, but we are still quite a ways away from this being a standard thing that we do in routine practice. That being said, while it is not funded in Canada, it does still have some potential roles, and you actually can get these tests commercially. I don't recommend you do this without talking to your doctor because firstly, they are expensive, and secondly, the information provided may not change your doctor's treatment recommendations, and that can be frustrating if you've paid $6,000 and the result doesn't change anything for you. The times where I see it as maybe being useful is if we're looking for a mutation and another biopsy is not feasible because of where your cancer is located. That could sometimes be a situation where it might be helpful. But in terms of monitoring disease response, I would say it is still very experimental. Okay, a next common question is for patients whose cancer has maybe only spread to 1 or 2 spots. I often get asked, why can't the doctors just cut it out and cure me of this cancer? And we actually did tests and studies looking at this many years ago. And unfortunately, cutting out those 1 or 2 spots doesn't improve patients' survival because the cancer just comes back somewhere else. It also doesn't improve quality of life because this procedures can often lead to complications and challenges. And so for this reason, cutting out those lesions is not standard of care and would only be done in very exceptional circumstances. Another common question I get is in patients who have metastatic breast cancer, some want their breast mass removed. And again, we don't typically do this because it does not improve the survival of the patient. The drug-based treatments that we will give typically work to control the sites of distant disease and also the primary mass that is in the breast. Surgery can be associated with complications like wound infections, and during this time, we can't give you chemotherapy, and often the cancer outside of the breast could grow during this time off of treatment. For this reason, we don't typically recommend going ahead with a breast surgery if you already have advanced disease. Okay, the next common question I get is whether or not there are clinical trials available or whether participating in a clinical trial is a good option for a patient. If you're thinking about a clinical trial, I think it's important to understand the different types of clinical trials. We largely classify them as one of 3 phases. Phase 1 clinical trials are often the first time a drug is being used in a human population or in this specific combination or setting. So they are very early phase trials, and they're typically designed to measure the safety of a drug. They're not designed to figure out if a drug is actually useful in terms of survival benefit. The phase 2 trials are where we first start to understand whether a drug has any activity. And then a phase 3 trial is typically a larger trial where we compare the newer drug to a standard treatment that we're already using to see if it is better than the current standard of care. There are also non-interventional trials. So these are things, for example, a trial that is collecting DNA, serial DNA, on a blood test to better understand the dynamics of ctDNA as they relate to treatment response. That's not a drug intervention, it's another type of trial, and those can be good options if you're interested in contributing to research, but don't feel like clinical trial intervention drugs are the right path for you. Clinical trials are essential to progress, and we are only where we are today in terms of our treatment options for patients because of those who participated in clinical trials before us. But they are not the right choice for everyone. So I do encourage you to talk to your doctor about them so you can make the best decision for you. I also get a lot of questions about diet. And the reality is there is not strong evidence to recommend one specific diet over another. I usually suggest a healthy, balanced Mediterranean diet is a good approach. If you go Googling on the internet, you will find a variety of diets like no sugar, keto, vegan, dairy-free, hormone-free, organic. Almost anything can be found on the internet as a recommended diet, but there isn't currently sufficient high quality evidence for me to recommend any one of these approaches over just a standard balanced diet. And then this is a really important one. Can I exercise? Some of you may have seen the headlines that came out over the last couple of months, both in Canada, but globally, related to this very interesting and important clinical trial that actually came out of the Canadian Clinical Trials Group and Queen's specifically. And while not related to breast cancer, I think the messages really probably transcend disease stage as well as subtype of cancer. So this very important trial prescribed a structured exercise program for patients who had been treated for an early bowel cancer. And they found that those who participated in this structured exercise program actually lived longer. I think the amount of support in favor of exercise for many aspects of life is really strong. So if you feel well enough to exercise, you absolutely can. Of course, if you have physical limitations from your disease, then this may not be an option for you. But if you're someone who likes to go for a run every day, then that is probably still a great thing for you to participate in. And then finally, I just wanted to end with 2 slides on shared decision making. Shared decision-making is a process by which patients are involved as active partners with clinicians in clarifying their preferences and goals of treatment. And we know that shared decision-making leads to improved patient knowledge, improved adherence to treatment, improves patient satisfaction, and therefore, for those reasons, can even lead to improved outcomes. So it's a really important facet of our current decision-making process. But it's not always easy, and it involves a number of important things. The patient needs to have knowledge in order to make informed decisions. Physicians need to provide adequate education and information for patients. Patients have to feel empowered to raise their opinions and voice their opinions in discussion with their physicians, and also need to be aware that they always have a choice. And then finally, one of probably the more challenging aspects is shared decision-making takes time. And those of you who are already within our cancer system are probably aware that our clinics are very overbooked and our resources can be challenging. So there isn't always as much time as we would like in order to have these shared decision conversations. So finally, sorry. Okay, so finally, some take-home messages. Metastatic breast cancer is not one single disease. There are many different treatment options, including chemotherapy, immunotherapy, antibody drug conjugates, targeted treatments, and endocrine therapy. There are important considerations for each treatment decision related to your personal preferences, the impact of the drug on overall survival and quality of life. So as you're approaching a treatment decision, please feel empowered to have your values and priorities be front and center to the decision that is being made. So I'll stop there. I think we have a good amount of time for questions, so I'll pass it back to you, Kathy. Thank you.
Well, first of all, I want to thank you for that wonderful presentation. Metastatic disease, cancer in general is a very hard topic to understand. And you started off by, teaching us a little bit about the vocabulary and how people can understand. And that to me is a very important way to discuss cancer with patients. Often they're like deer in headlights and they don't understand what they're learning because of the technical terms, the research terms, the medical terms. So I want to thank you for that. And also thank you, in case I forget, for the slide on combined decision making with your physician and other multidisciplinary care that you may be involved with, because I think that we want to agree that there is too much push on patients to tell them you must be involved with the decision making. I agree. And being a patient myself, I understand that. But it does take time and it does take quite a bit of understanding. So it's not for everybody. And I think you have to understand the limitation of embarking in something like this. So that's very valuable to put that in your presentation. And I want to thank you for that. And thank you for the general approach and how you presented this metastatic disease presentation. So I'm going to go on to some questions I have. And in terms of when you speak about spread to, distant parts of, your body after, you've been diagnosed with metastatic, can you define spread also to a lymph node or minimal invasion to lymph nodes? Because that often happens. Is that considered metastatic, and at what degree is it considered metastatic?
Yeah, so that's a great question. And I think that's a place where terminology can actually be quite confusing because you might read in your pathology report that you have breast cancer that is metastatic to your lymph node. And whenever you see that word metastatic, people automatically start to think incurable stage 4 cancer. But in the context of a breast cancer in a regional lymph node or a metastasis to a regional lymph node that has been removed, that is still a curable condition. So spread to local lymph nodes can still be cured, even though some people do use the terminology metastatic to the lymph node. Now, if you have metastatic lymph nodes that are not regional, so for example, way up in your neck or down in your belly, that is not a curable lymph node. I tend to try and avoid using the word metastatic to the lymph node because I do think it is quite confusing.
And I think it is not used as a term when it's to the lymph nodes. I don't think it's ordinarily
Not
used.
not usually, but you will see it in pathology reports. And I think
Biology.
there it can create a lot of confusion for patients because they come in saying I have metastatic lymph nodes, but it's really used in that pathologic definition rather than us saying that you have metastatic disease elsewhere.
Which brings us back to that slide of where you say combined, you know, uh, therapy decision making, same as reading your own pathology, reading your own information. That also requires some sort of understanding of what you're reading, because that could be inducing so much stress that is avoidable. So it's up to a patient to decide how they want to go about it. But those two are areas that, can cause more stress than you should have. That clears that. Going back to your slide, in terms of what to do to investigate if you have, how you're doing with your metastatic disease or if you're going to be diagnosed, PET scan. Lots of people think of it as a Star Trek movement, like you just go and you scan. It's the entire body. I'm scanned. I'm done. Everything is good. Can you please touch on that? Because there's so many misinformations around that.
Yeah, this is actually a really challenging area, I think, in breast cancer right now, for patients, but also for clinicians because it's evolving and changing. So if we focus on patients with metastatic disease, where I think it's a little maybe clearer to understand its role, I, Think that if you have breast cancer that we can see on a CT scan and we can see on a bone scan, and we already know it's there, and we already have a treatment plan for that, a PET scan will often find more disease than we see on the CT or the bone scan, but finding an extra 1 or 2 spots is not necessarily going to alter your management plan if you already know it's there and you're already embarking on treatment. The time where I think PET scans may be more helpful or are perhaps being used a little bit more are in patients who have a locally advanced breast cancer, so a high risk early breast cancer, where we're trying to understand if it may have spread elsewhere. But even that, I find, is very controversial because one needs to acknowledge that in all of the clinical trials that we have done to date, our decisions to embark on curative intent therapy were based on a bone scan and a CT scan. There is potentially a small proportion of patients who, in those studies, might have had distant disease that you found on a PET scan who could still have been cured by a curative approach. So when you do that PET scan, what we know is that we'll pick up more metastatic disease, but we don't know if that's going to take away what could have potentially been a curative pathway for patients with very low volume metastatic disease, because that's not a study that we've done. The studies have just shown that we pick up more breast cancer that has spread. So this is a very tricky area. And we do have funding for PET scans to be used with patients who have stage 3 breast cancer, or stage 2, in fact. And I think it should be used carefully. So I have a very long discussion usually with my patients, because if we find something, we may find something that leads us down a path that they may or not be, happy that we're pursuing, as in metastatic disease and a non-curative approach.
And I would think that it's probably used more for other cancers, that you may find a patient's blood levels are giving you radars, right? But you don't quite understand, say, ovarian cancer or gynecological cancers or some intestinal cancers. And you say, well, we want to find out where exactly it is because it might start off very small. Is that better use than breast cancer?
So yeah, I think it's different, and I think it's related to, how long have we been doing it? What is the strength of evidence and the benefit for the decision-making process? So, we use it a lot more in other cancers, as you said, like lung cancer and esophageal cancer. It's really standard as part of our baseline staging. But I think that the benefits there are a little bit better established at this point in time. So it's not to say that PET scans are not going to be used more and more in breast cancer. I think it's more that we need to ask the right questions and collect the data before we start doing PET scans on everybody.
Right. So metastatic disease is not curable.
Correct.
Actually, cancer is not curable. Correct me if I'm wrong, but is it because of the therapies that are not really doing their targeted job? How can you explain to us from a medical perspective why all these combinations and all these targeted therapies are still not able to do the job?
So I think that's, that could be a 2-hour to 5-hour lecture in and of itself. It's complicated. There are probably ways to break it down. So one way to think about it is the environment of the tumor itself. Tumors the drugs need to penetrate into the tumor in order to kill off all the cancer cells, and tumor cells have ways to kick the drugs out. They have ways to insulate and protect themselves from the drugs acting as they're designed to do. So the drug will not always be able to attack or reach all of the cancer cells that are there. So that's one challenge. Number 2 is the cancer cells change over time. So even if a drug works for a period of time for a patient, just like Darwinian selection, the cells that are vulnerable to that drug will die off, and the cells that develop ways to become resistant to that drug will start to grow. And so that's why we see this typical thing with on imaging. You get a response, you get a period where everything's stable, and then eventually you get growth. And that growth is because what is growing now is resistant to the drugs that you were using. We could kill cancer. If we gave all of our drugs together in a petri dish, we kill cancer. The problem is we kill patients too. So it becomes a balance between how much drug can we give to kill the cancer and how tolerable is that for the patient who has to live with the consequences of all the therapies that we give. So it is a challenging, difficult balance. I think there are lots of interesting novel approaches and technologies that are addressing all of these various aspects and challenges, but we are not, I don't think, going to be seeing a cure for metastatic breast cancer anytime soon. Maybe we will in the future. I think we all hope for that, but I think we're still, unfortunately, a little ways away.
So we're chasing all the time and we're trying to attack all the time. So it's
Yeah,
kind of a
that's right.
circle that's just going
It is.
round and round.
Yeah.
Okay.
So we need to be dynamic with our treatments and be able to change and rotate. But we don't always succeed with the things we choose.
Right. So staying with the therapy section, you actually covered well, I don't know if it's non-therapy. So you did diet, you did exercise. What I'm going to ask you, because out there it's a world of vitamins. I'm going to get on all these vitamins and I'm going to do creatinine and I'm going to do this and I'm going to do all this stuff, and patients get bombarded with this and get really involved in this. Even medical people are trying to, get themselves to be in a better state because they're going to put these combination vitamins. How does that interfere with cancer and with cancer treatments?
Yeah, so great question. I get a lot of questions about supplements and things. I think many of us do. And my answer is usually that we don't have high quality evidence that any of these supplements are going to help overall survival outcomes. And that's what matters most to many patients. If we did, we would recommend them. They're often not very expensive. They're a heck of a lot cheaper than these drugs that cost $10,000 a year or a month even. So if we had high quality science that they would work, it would be so much simpler to give, a vitamin C rather than some of these chemotherapy drugs that we have to deliver. I also rely on a very interesting study that was published a couple of years ago now in our leading oncology journal, which looked at survival outcomes for patients who were taking lots of supplements versus those that weren't. And the patients who were taking a lot of supplements actually had inferior overall survival. Now, that is not a randomized trial. It was not, take two groups of people, give these ones supplements and don't give these ones supplements. It was more looking, how do people do if they chose to not to take supplements or not. So it's not a clean study, but I think it tells me that certainly we don't have any strong signals there that taking supplements will necessarily improve your outcomes. And there's a lot of reasons that it might actually do bad things for you, because many of these drugs or supplements, firstly, are not always regulated. So we don't actually know what's in them sometimes. There's no clear regulatory system that requires labeling of ingredients and testing. So sometimes patients don't even know what they're taking. And then secondly, they can interfere with the way our body processes our chemotherapy. That can cause different things. Sometimes that means that the chemotherapy drug levels in our body are lower than we anticipate, so the drug doesn't work as well. Other times it means the drug levels are higher than we anticipate, and patients can get bad side effects because they're getting essentially more chemotherapy than we intended to give with the dose that we gave. So I think it's complicated. I think that, if you want to take a multivitamin a day, I don't think there's going to be any harm to you from that. I think that's absolutely fine. But if you are going to think about some other supplements that maybe are in higher doses and that are less clear, then I usually recommend you speak to your cancer pharmacist. They are an excellent resource. They will be able to tell you, what is likely in this drug, how is it regulated, is it likely to interfere with the cancer treatment that you're getting, and then you can make an informed decision. And then finally, please share with your team if you're doing that, because we will always try and work with you. Ultimately, it's your body and it's your choice. But our number one priority is not to do harm. And sometimes these supplements actually can do significant harm. And I've had events where patients have been taking things without telling me, and they end up in like liver failure because they combination of the chemotherapy and the supplement was just a really bad combination for the individual.
Thank you. That's very, very important for you to clarify. I'm going to go to questions that were submitted. Question number 1, do you know how much fluorescent is per month if somebody wants to pay for it?
Yeah, that's a great question. So we have so many drugs now that are not always freely available that require us to go through our drug access coordinators that I honestly can't remember the price off the top of my head for all of them. It can be very challenging given the number that fall into this category. But in Ontario, where I work, even though it's not an injectable drug, or sorry, I should say not an intravenous drug, and therefore it's not covered in our typical cancer funding plans, it is available for coverage for almost everybody. We just have to jump through hoops. So there's additional paperwork, there's additional funding paths that we access. I prescribe this drug all the time, and I've never had to have a patient pay for it out of pocket. So you just need to speak to your doctors. You will likely be able to find a way to get it, certainly in Ontario, without a fee. It just requires some extra hoops.
Thank you. Next question. Is it possible to pay for fluorescent if the ESR1 mutation is present, but there are no mets?
No. So we did do studies in the past looking at fulvestrant in the adjuvant setting for patients who might have emerging mutations, and it was not found to be a successful strategy. So it is not funded for that indication, and I think you would struggle to find a clinician who would prescribe it for you because that's not part of the Health Canada label.
And the next question is about a drug, Anktiva, a PD-1 targeted drug.
Okay, hold on. I suspect that has another name.
I think it's Anktiva, a PD.
Yes. So this is an immunotherapy drug that's being, I think, explored more in bladder cancer. It's not one that I'm aware of any clinical trials being run in breast cancer right now, but that's not to say there aren't phase 1 or early trials in development. I'm not aware of any phase 3 studies investigating this drug right now.
And the next question, what's the survival rate for HR positive, HER2 negative patients?
Yeah, so great question. Obviously, when we think about survival rates, the usual numbers that we give are averages. So we can never say for any individual one patient what the survival will be. But for someone newly diagnosed with ER/PR positive, HER2 negative breast cancer, average survival can be up to 3 to 5 years. We have good success now with our first line therapy, and patients will often be on that for 18 months to 2 years. And then after that, we have other drug-based treatments, targeted therapies, hormone therapy, and then chemotherapy eventually when we've run out of targeted and hormone therapy options. So survival can still be on the order of years. Now, I usually reevaluate those prognostic timelines because if I have a patient who goes on to first-line therapy, where I expect them on average to be on that for 18 to 24 months, and then I find that they've progressed at 6 months, well, that's going to tell me that this is an aggressive type of biology, and their prognosis is likely going to be a lot shorter than those averages. So, as patients, I encourage you, just because you got an answer about your prognosis at the first appointment, ask again because it changes. The information changes as we understand how you're responding to treatment and what treatments we have available for you. So it is always a dynamic discussion to try and figure out what your prognosis is for any individual.
Okay. Can an HR positive cancer benefit from PARP inhibitor?
Yeah, so it can. And in fact, we now have funding for PARP inhibitors in the adjuvant setting. So if you have certain disease characteristics and a BRCA mutation and you are being treated in the curative setting, but you have very high risk disease, we actually have funding to use olaparib in what's called adjuvant treatment. So that means after your chemotherapy, your surgery, and then after that, we would have funding to use it. So we do have PARPs funded in the curative setting. We just don't have them funded in the metastatic setting. But if you had a hormone receptor positive BRCA mutated breast cancer that was metastatic, you could explore paying for olaparib if that was of interest to you.
Is anyone tracking when metastatic breast cancer patients are told they have no evidence of disease?
Yeah, so I think what you're referring to there are patients who've had what we call a complete radiographic response on imaging, meaning we know you had disease and then you've been treated and you've had a really good response and we can't actually see anything on our standard imaging anymore. And I think this is where there's a lot of interest to using ctDNA because we could, you can envisage a future where there's nothing on the scan. Instead of doing a scan every 3 months, you just get a blood draw and we watch the dynamics of your ctDNA. And if they're not changing, well, then maybe you stay off therapy and monitor. And then if it starts to rise, you do a scan to detect recurrence on imaging early and then reinstitute treatment. So I think the short answer is right now, most patients would still have regular CT scan monitoring, but this is an area of very active research and interest right now.
So the next question is, do you recommend stage 4 metastatic breast cancer patients continues screening for other cancers?
Yeah, that's a really interesting question. And I think that it depends what other cancers you're looking for. And it also depends on, I think, where you are in your metastatic breast cancer journey. So for example, if you have a highly aggressive triple negative breast cancer where we know that unfortunately your prognosis may be 12 to 18 months, well, then detecting a early polyp from a bowel cancer screening program is probably not going to change your survival in any way, and so may not be useful to you. On the other hand, if you have a HER2 positive metastatic breast cancer, you've been on treatment for 6 years, you have no evidence of disease progression, you're still on your first line therapy and you're doing great. Well, I think in that situation, picking up an early bowel cancer could be quite useful to you because your prognosis from your breast cancer is probably still very good. So I don't think there's a yes or no or clear-cut answer to that. I think that those are things that really do warrant discussion with your family doctor or your oncologist, ideally, who has probably a better understanding of your prognosis. And they're complicated decisions, so they definitely warrant discussion.
Okay, and now that, we're coming short on time, I just want to ask you, so there's always like these survival and overall survival and how well you do on these drugs and, 2 months, 4 months, 6 months. In general, what are like some people live for a very long time with metastatic disease, and that is always told by medical oncologists. We have patients with long lives after So how does one wrap themselves around that whole thing about 2 months, 4 months, 6 months? Are you going on the low? Do you have a high? Like what? That's not very clear to all patients.
Yeah, and I think this is one of the most difficult things because what we really lack is biomarkers. So that word comes back, but biomarkers to help us really predict who's going to be a long-term responder from a certain treatment, whose cancer biology is likely to be a little bit slower growing and therefore have longer prognosis. And so when I talk to patients, and I think when most doctors talk to patients, what we can really only rely on is those averages. But averages are just that. 50% of people do better, 50% of people do less well. So I try and emphasize that. If the available evidence gives me ranges, so for example, how did the person, what was the outcome for the best performing patient and what was the outcomes for the worst performing patient? Sometimes those ranges can help people understand what the possibilities are. And I think hearing those, individuals who do have long-term survival is very helpful for patients in that it helps provide hope, and hope is really important in our cancer journey. But I think it's also important to recognize that those are usually the outliers. So we don't achieve those sorts of outcomes for everybody. So while we always hope we achieve that for every individual, those cases tend to be the rarer situations. So I think we should always hope for them, but we should also counsel and educate patients on the most likely outcomes so that they can plan and make informed decisions. And if we happen to have those spectacular outcomes, then we all celebrate and go to the pub.
And would you say that's true also for bone metastases from a breast cancer?
Yeah, so we do have some, I guess, what we would technically call biomarkers for prognosis. So we know that patients who have, for example, liver metastases tend to have worse overall survival outcomes than someone who, for example, has bone-only metastases. That tends to be associated with longer survival. So these subtle differences, often your oncologist will kind of use that to inform the discussion. So if I have a patient who has 2 bony lesions, I'll tell them, the average survival is this, but in that population includes people who have 10 liver lesions and a brain met, and then people who have 1 spot in the bone. And you're much more like the 1 spot in the bone. So if I had to hazard a guess, I think your survival will be longer than that average. But it's important to also make sure that we recognize that cancer can change quickly, right? Just because someone has only 1 or 2 bony spots at one point in time, a mutation can suddenly develop that changes that situation quickly. So it is a dynamic disease. It is constantly changing, and I think always warrants rediscussions about potential prognosis because it can shift.
And so before I do my closing comments, can I ask you, where are we in the landscape of making this disease more normalized, I guess, like a diabetic disease, or are we there? Are we still confused? Yeah, chronic. Are we still confused? Are we still not, able to get it to a level where we can say, you know what, we're doing so much better now? And do you have any sense of where we're going with this?
Yeah, I mean, I think we are doing better. Those survival curves show you that our outcomes are improving, but we still have huge numbers of women who die from metastatic breast cancer in our country and all over the world every year. So it is not a chronic disease yet for most patients. Sure, there may be a subgroup who do have excellent long-term outcomes, and we all have those patients in our clinic, and we need to better understand how we identify them and leverage whatever's going on with their treatment responses or biology in order to try and translate that to other patients. But I think there's a lot more work to do. I, for the most part, don't feel that I would call breast cancer a chronic disease. Yes, some patients live for a while and we have to manage the chronic toxicities, but I see every day women for whom this is not a chronic disease. This is an acute illness. So I think we do need to still definitely work very hard on finding further treatment options for these patients.
Thank you. And so I'm to the point where I have to give my closing remarks here. Thanks. And that concludes our time for today's session. Thank you everyone for your questions and for joining us to learn about metastatic cancer. And again, I want to thank you, Dr. Wilson, for being here today, but mostly for making it such a clear and understandable presentation. And I know that's very difficult. Thank you. And thank you again to our sponsors, Novartis, Pfizer, Gilead, Bayer, Tessera, AstraZeneca, and Lilly Canada. Following this session, you will get a link to complete a survey to provide feedback on this session. Please consider leaving feedback, as this really helps us improve future sessions for attendees like yourself. Once the recording is available, Rebecca will share a link along with resources shared in today's session. And with that, have a wonderful afternoon. Thank you.
Thanks very much.
Thank you, everyone.